Right, 350. Okay, right. So coming to the basic checklist of operative dentistry. So there are two quick revision videos. So few concepts in the quick revision videos I try to cover here, but I want you to watch those two videos. One is of 20 minutes and second one is of 45 to 50 minutes. So make sure, please don't miss that old quick revision videos which are already available. And people who has access to ProLive, make sure you do it. And people of offline, please try to attend the offline class which we have tomorrow. Okay, don't miss it. It's mandatory things. Right. So like once you're done with this, go back and try to finish your subject specific of operative dentistry available on the website. I don't know how many of you done it. If not, please try to finish it. Okay. So we'll start. So only dental structure which is ectodermal in origin. Only dental structure which is ectodermal in origin. Yes, only dental structure which is ectodermal in origin is, yes, right, that is enamel. So normally if they ask tooth, the mode of origin of teeth is, ectoderm in origin is enamel, the mode of origin of teeth is, yes, origin of teeth is ectomesenchyme. Can you tell me which salivary gland has ectodermal in origin? Only salivary gland which is ectodermal in origin is. Only salivary gland which is ectodermal in origin is parotid gland. Right, chalo. So let's start. Mostly it will be a one-way session. Okay, so let's start about the caries. Initiation of dental caries is basically by Streptococcus mutans. Okay, whereas the progression of dental caries occurs by lactobacillus, and root caries is caused by which organism is responsible for occurrence of root caries? Yes, root caries is caused by actinomycosis. Very nice. And root caries, I want you to add few important points. Root caries, normally root is basically surrounded by cementum. So root caries is also called as cementum caries. And root caries is most aggressive form of the caries. It is the most aggressive form of the caries. And in the cross section, you see U-shape. U-shaped cross section is seen in which of the following caries lesion? The answer is root caries. Started. Guys, please don't write on my screen. Okay, so most aggressive form of caries is root caries. Can you tell me what is the restorative material of choice for root caries? And root caries is most oftenly associated with gingival recession. So yes, restorative material of choice for the root caries is GIC. Very good. Right, it is GIC. Next, I want you to add one important point about sanguis. Sanguis prevents the colonization of Streptococcus mutant, and this method of preventing the colonization of Streptococcus mutant by sanguis is called as colonization resistance. And similarly, the first organism to enter into the oral cavity is Salivarius. Okay, so normally Streptococcus mutant will come into oral cavity only after the tooth eruption. Okay, so once the tooth is erupted only, Streptococcus mutant, because Streptococcus mutant is going to hang on the tooth. Okay, so the teeth are required for Streptococcus mutant to exist. So now you have one question, an integrated question of operative dentistry and pedo. So during which phase there will be huge increasing the number of organisms or huge increasing the number of Streptococcus mutant in the oral cavity? So hope you have exposed to this question, which is a neat repeat. It is basically the transformation from that of the primary dentition to the permanent dentition. From primary to the permanent. So is a phase where there will be increasing in so the gap between the primary and the secondary. Okay, that is the primary and the permanent. So this gap, there will be increasing in the number of Streptococcus mutant in the oral cavity. Okay, so then, yeah, right. So you have a question given in the examinations related to this. Simple restoration is something which is involving one surface, compound is 2 surface, and complex is more than 2 surface. These are basically external surfaces. Okay, so these are basically external surfaces. If a restoration is involving 1 surface, it is called as simple. If it is involving 2 surface, it is called as compound. If it is involving more than 2 surface, it is called as complex. So you have two varieties of questions which are given in the latest examinations, that is 2024 NEET exam. Okay, so the question is, a student or a dentist has prepared a cavity. Okay, has prepared a cavity which basically involves 4 walls, during his preparation. This comes under which type of restoration? Basically involves 4 walls. Now, let it be very clear with the question. While preparing the cavity, it involves 4 walls. Means that he is telling the restoration is having 4 walls. Okay. Or the cavity is having 4 walls. He's telling the cavity is having 4 walls. Cavity is having 4 walls means class 1. You take class 1. Class 1 is going to have a buccal wall, a palatal wall, mesial wall, distal wall. So it is having 4 walls. The cavity prepared is having 4 walls. But the restoration is having how many walls in class 1? For example, you take this scenario, the restoration is having how many walls? The restoration is occupying only 1 wall. So then it will be simple. This is one mode of question. The second mode of question is a restoration which was prepared by a dentist involving 4 external walls. So whenever it is involving 4 external walls, okay, the restoration involving 4 external walls, more than 2 walls, then it is going to be complex. So see, I don't know which format of question was given in the 2024. These are the 2 variations of info that is given by the students. So these are the 2 different questions which were given. Both are very easy, simple from the basic classification, but it's about how you understand the question in the examination that is more important. So jumping into the subtypes of Streptococcus mutant. So this table is very, very important. Okay, out of which, okay, the Streptococcus mutant, basically the subtypes of Streptococcus mutant which causing the dental caries are C, E, F, K. They are C, E, F, K. So they can ask you most common serotype is. What is your answer? Most common serotype is easy to remember. C for common, C for C. So most common serotype is C. C followed by E, followed by F, and followed by K. This is the sequence. And one frequently repeated question is, Streptococcus rattus comes under which serotype? So rattus comes under, it will be seen in the rat. Rattus comes under serotype B. The others are also important, but I am stressing the questions which are previously given in the examination. Okay. So I'm jumping into the next part, bleaching, that most of you are familiar about bleaching. So which ingredient you are familiar in the bleaching? Which ingredient? Yes, most of us are familiar about hydrogen peroxide, which is nothing but called as soperoxyl. What is basic definition of soperoxyl? Soperoxyl is nothing but 30 to 35% of hydrogen peroxide by weight, or 100% of hydrogen peroxide by volume. This is a basic definition of superoxide. Okay. What is this volume? Volume means amount of oxygen that is released. Means 30 to 35% of sodium hydrogen peroxide by weight is going to release 100% of oxygen by volume. Clear? So that is superoxide. They can ask you the basic definition. Can anyone tell me MAC value of nitrous oxide? MAC value of nitrous oxide? Yes, MAC values of nitrous oxide is 104%. Very good. So you have non-vital bleaching techniques and vital bleaching techniques. Non-vital bleaching techniques are basically done in the non-vital teeth. Basically done in the non-vital teeth, whereas vital bleaching techniques are done in the vital teeth. Okay. So in non-vital bleaching techniques, you have something called as thermocatalytic, means temperature. Okay. Temperature is basically activating the reaction, means thermocatalytic. Thermal means change in temperature is basically initiating the treatment. Okay, so placing of 30 to 35% of hydrogen peroxide liquid in the pulp chamber, and the oxidation process is accelerated by placing a heated instrument. Means here heat or thermal temperature is acting as a catalyst to initiate the reaction. So that is called as thermocatalytic technique. Second one is walking bleach, very frequently asked question. So walking bleach, what we regularly used in the walking bleach is we use hydrogen peroxide in combination with sodium perborate to accelerate this oxidation reaction. So very frequently asked question, which of the following is the major ingredient in walking bleach or major ingredient in non-vital bleaching techniques? The answer is sodium perborate. The answer is very frequently asked question. The answer is sodium perborate is the answer. Okay, right. The next one, jumping into the vital bleaching techniques. In vital bleaching techniques, in office, we do. So that is a combination of ether, hydrogen peroxide, and HCl. What is this solution basically called as? What is the name of solution? Yes, this solution is basically called as McKean's solution. Anyway, we'll be discussing in the next part. Okay. The second type is night guard. So what is the ingredient that is used in the night guard? Apart from hydrogen peroxide, what is the other ingredient that is regularly used in the vital bleaching is? Yes, that is your carbamide peroxidase. So range, if they ask, the answer is 10 to 15. If they don't ask range and very specifically targeting about the number, then the answer is 10. 10% of carbamide peroxidase, which degrades into 3% of hydrogen peroxide and 7% of urea. And this hydrogen peroxide is basically the active component which is causing the vital bleaching. So night guard, what is the bleaching agent that is used? What is the bleaching agent that is used? Yes, very good. Carbamide peroxidase. Whereas walking bleach, yes, walking bleach is sodium perborate. Okay. So I told you, right, McKean's solution. So you have two important things to be noted. One is McKean's solution, basic McKean's solution. Second one is modified McKean's solution. McKean's solution is basically 1:5:5 ratio of one part of anesthetic ether, which is 0.2%, helps in removing the surface debris. And the second one is 5 parts of HCl, 36%, which helps in itching the enamel, by which it increases the absorption of H2O2. The second one is 5 parts of H2O2, that is 30%, which helps in bleaching the enamel. And as we all know, okay, there is lots of issue whenever you're using HCl because of its acidic pH, right? So you know, right, HCl is present in the stomach. So what is the pH of gastric fluid? What is the pH of gastric fluids? Yes, pH of gastric fluids is around 1 to 2, which is so acidic. Okay, so it's going to be difficult. So that is the reason why in modified McKean's solution, they tried their best to remove HCl. So what they have done, they removed HCl and they have added one more agent. So that is very, very important. So the next one is what is the modification that is done? That is, they have added NaOCl 20%. Here, their acidic pH is causing the enamel dissolution or itching the enamel. Here, alkaline pH helps in dissolving the enamel at a comparatively slow rate. You have your hydrogen peroxide at same percentage, that is 30%. So they can ask you, what is added? What is added in modified McKean's solution? What is added in modified McKean's solution? 20% of NaOH. Then comes to the microaberration. So in microaberration, basically Kroll's technique, where they initially have used 18% of HCl, and in modified Kroll's technique, they have reduced the percentage of HCl to 11%. So they can ask you, modified Kroll's technique, what is the percentage that is used? 11% of HCl that is used. So there is one concept related to the bleaching and composite restoration. So a patient came and non-vital bleaching was done. And yeah, the bleaching is over. So now you have to replace the temporary restoration with a permanent composite restoration. Can you do it immediately? Can you do it immediately? No. Why? Why you cannot do it immediately? Yes, because of the free radicals, because of the oxidation environment that is present, which hinders the bonding property of the composite. So either you have to wait for a week. The one option is wait wait for a week. Second option, if you want to do it immediately, what you can do? Yes, if you want to do it immediately, you need to add an antioxidant. So according to the student, the antioxidant they have given is catalase. Any antioxidant, even vitamins can be used, but preferably an antioxidant catalase has to be used, okay, for 3 to 5 minutes, after which means you are going to remove that oxidizing environment, and then you can go for a composite restoration. So composite restoration cannot be performed immediately in a bleached teeth. The reason is it is going to hinder the bonding properties. Either you have to wait for a week, or either you have to keep an antioxidant, catalase preferably, and you can go for the bonding. Clear? Okay. So next one I want to focus is a little bit on lasers. So lasers, the full form of laser is light amplification by stimulation emission of radiation. Scientists who are concerned with lasers in dentistry and scientists who are concerned with lasers in endodontics, if you want, you can make a note of it. One frequently asked question is, whenever you use lasers, or whenever you use these light curing devices, the most common part of eye that is damaged is which part? The most common part is retina is most commonly damaged, and least commonly affected is pupil is least commonly affected. These two are frequently asked questions. So then I'll jumping into all these are like everything is questions, very, very important. So please do make a note of it. The first one is ERYAG or ERCRYSGG. It's a solid active medium crystal containing, please do make a note of it. And particularly the most frequently asked questions is the wavelength. Okay. So wavelength of ERYAG is 2940 nanometers, whereas ERCRYSSG is 2790 nanometers. Okay. So what is the advantage of this wavelength? These wavelengths has highest absorption in water. Okay. And they have high affinity to hydroxyapatite crystals. So you know that the hydroxyapatite crystals are present everywhere in every hard structure of the teeth. Okay. So it is more often inclined to hard cutting laser. So, right. So the clinical usage of this is ideal for hard tissue cutting and drilling. Okay. So that is an advantage of ERYAG and ERCRYSGG. The next comes is NADYAG. So NADYAG wavelength they can ask you. So that is 1064 nanometers. It is basically the first design laser exclusively for the dentistry, and you can deliver this rays in the pulse mode, and it's most commonly used in contact with the tissue. So this pulse mode NADYAG laser is ideal for soft tissue procedures and root canal sterilization. So ERYAG and ERCRYSGG is for hard tissue, whereas NADYAG is for the soft tissue. Next one comes with the diode. Okay, so diode laser, the wavelength is very frequently asked question, that is 800 to 980 nanometers, and it is poorly observed by the dental structures. Hence, soft tissue surgeries can be safely performed in close approximation with the dental structures. Which department is going to do soft tissue procedure closely associated with hard tissue? Yes, very good, simple, perio. So it has poor absorption with the tooth structure, hard structure. So it's not going to hurt the hard structure, but it can play with the soft tissue. So it is most commonly preferred in the perio department. So diode lasers are well observed by the pigmented tissues, and it's a good soft tissue surgical laser indicated for cuttings and coagulation of the gingiva, which is used in the perio. Then comes the only laser where UGs are allowed to touch. Which laser? Yes, composite curing laser. Curing lasers, right? So that is organ laser. It's going to have argon gas, and it has two emitted wavelengths. One is 488 nanometers, which is blue color, regularly what we are going to use. And second one is 514 nanometers, which is blue green color. And one frequently asked question regarding this is, which of the following is a single wavelength laser? Which of the following is a single wavelength laser? Yes, the answer is same again. Organ laser is a single wavelength laser. So what happens? What is the advantage of this 488 nanometers? The 488 nanometers is the exact wavelength where it's going to activate camphoraconin, which is present in the composite. So that is how this light activated composites or impression materials or bleaching agents are going to start their work. The second important wavelength that is mentioned in the textbook is 514 nanometers, is the absorption of hemoglobin. Okay, and it helps in stopping the bleeding. Okay, so two wavelengths are regularly used with organ. This number slightly varies. Some if few areas it is given as 474 nanometers, few areas it is given as 488 nanometers. Don't worry about the exact value. Okay, so among the options, go for the closest value. So what wavelength regularly you use for a composite curing? That is around like 470 to 480. So which wavelength is regularly useful for blood hemostasis? Yes, that is on other side. That is 514 nanometers. Here you have a wide range of questions which I have given related to the lasers. So please go through this. Okay, lasers which is used in Laskin surgery, that is organ fluoride laser, and lasers which are used in pulp therapy, lasers which are used in hard tissue procedures, lasers which are used in pit and fissure sealants, laser used in composite, laser used in TMJ surgery, laser used for hemostasis, and then comes few questions on wavelengths. I told you that single wavelength laser is organ laser. First laser used in dentistry. Similarly, I have given many. Okay, laryngeal surgery procedure is done by carbon dioxide laser. Laser with the longest wavelength is carbon dioxide laser. Okay, so please go with this, all these single liners, which are very, very important, frequently asked areas related to the lasers. So then I want you to focus on modified class 3. So modified class 3, regularly they are going to have a dovetail, which they extend either on the lingual side, that is on the palatal side, or sometimes that will be extended on the labial side. Particularly whenever you take a maxillary canine, okay, this will be extended on the palatal side. For a mandibular canine, this dovetail will be extended on the labial side, right? Max, it is on the palatal side, whereas mandible, it is on the labial side. Again, you have a question on this, so that is the reason why I kept this diagram in front of you. Clear, guys? Right? Hope my pace, the speed with which I am going is fine. Right? Clear? Fine? You want me to go at a slower pace? Right. Okay, chalo. Next one, there is something called as SMART. What is the SMART? SMART is silver modified atraumatic restorative technique. So in this SMART, basically, okay, we are going to use a combination of SDF and GIC. SDF and GIC. SDF, S stands for silver. Okay, so most of us are familiar about SDF. S stands for silver. So what is the property of silver? The silver is having a property that it is going to kill the bacteria. So it is silver is having antibacterial property. It is going to kill the bacteria. And what is the purpose of GIC that is used in SMART is GIC is going to seal that area, form a chemical bond by which it cuts the nutrition supply to that of the bacteria. So that is called as SMART. What is SMART is silver modified ART. Silver modified ART is called as SMART. It uses a combination of SDF and GIC. The purpose of using SDF is to kill the bacteria, and purpose of using GIC is block the nutrition to that of the bacteria. I hope this is very, very clear. Okay, anyway, SDF, we will try to go and handle it as deep as possible. But here I want you to make a note about few important points. The percentage of SDF, like in a fluorides that most of you know the decent numbers, right? So APF, what is the percentage of APF that is used? 1.23, very good. SNF2, how much percentage? SNF2? Yet SNF2 is 8%. APF is 1.3%. NAF? NAF. Yes, we regularly use 2% of NAF. Similarly, what is the percentage of SDF that is used? What is the percentage of SDF that is used? Yes, the percentage of SDF that we regularly use is 38%. When they're asking ppm, it is 44,800 ppm. Very, very frequently asked questions. Nowadays, SDF is a very, very commonly encountered ingredient both in NEET as well as in the INICET. And it is one of the highest among the list. Okay, right? And it's going to contain 25% of silver, 8% of ammonia, and 5% of fluoride. Main use of silver is already discussed. What is the main use of silver? Silver is antibacterial. Okay, then most of you are familiar regarding this miracle mix. So what is this miracle mix? Yeah, miracle mix is basically mixing of GIC type 2 with a spherical silver amalgam alloy. Spherical silver amalgam alloy. Can anyone tell me what is type 2 GIC? What is type 2 GIC? Yes, very good. Type 2 GIC is restorative GIC. Very good. Then comes, I just want to add a note about sandwich technique. Most of you are familiar, open sandwich technique, closed sandwich technique, already discussed in the quick revision videos. So it's a combination of basically GIC plus composite. If the GIC is exposed outside, it is called as open sandwich. If the GIC is closed by composite, it is called as closed sandwich. Can anyone tell me where do you see sandwich vertebra? Sandwich. Where do you see sandwich vertebra? Already discussed. Yes, very good. Osteopetrosis. Osteopetrosis. And similarly, you see rigorous spine also in the case of your osteopetrosis. Very nice. And I hope like most of you are familiar about the C factor. Can you tell me what is the formula of C factor? So it is bonded surfaces by unbonded surfaces. Okay. So as C factor increases, your polymerization shrinkage stress will increase because C factor polymerization shrinkage stress is directly proportional to bonded surfaces. So as C factor increases, your polymerization stress or polymerization shrinkage is going to increase. C factor is highest for yes, class 1 and class 5. How many bonded surfaces will be there? How many bonded surfaces will be there? 5 bonded surfaces. How many unbonded surface? The surface which is exposed outside is unbonded. So C factor for class 1 and class 5 is 5. If both are there in the options and you need to choose only one, which is highest, 1 or 5, then your answer is 1. Then your answer is 1. Right. And everything next, C factors and everything, I hope you can calculate. That's not an issue. So simple way is 1, 2, 3, 4, 5 is 5, 4, 3, 2. 4, 3, 2, 1. So simple way of arranging this order is 1, 4, 3, 2, 1, 5, 4, 3, 2, 1. 1 we are not calculating. 1 we are considering, 5 we are considering it as 5 by 1. So rest all of these are the values. What are the value? C factor for class 1. Standard C factor for class 1 is 5 by 1. Class 2 is 4 by 2. Class 3 is 3 by 3. Class 4 is 2 by 4. Clear? C factor for root canal is? C factor for root canal according to Phillips is around 1000. They have given it as a statement around 1000. And C factor for MOD. MOD means 1, 2, 1, 2, 3. Means all the buccal walls you're going to consider as 1. All the lingual walls. Basically, you have 3 walls, but you're going to consider it as 1. All the lingual walls, you're going to consider it as 1. And all the palatal side, you're going to consider it as 1. So it is 1, 2, 3 by mesial, distal, occlusal. 3 by 3. The answer is 1. This is according to one of the standard reference textbook. If you want to calculate exactly, you can calculate. Like a few of the mentors, they can prepare such a question, but according to textbook based reference, it is basically 3 by 3. If not, you can calculate basing upon the number of walls according to the cavity, whatever you have prepared and whatever they have given in the exam. Clear? Okay, then comes, I mean, like, you see, like the first one is chemical cure or self-cure, and the second one is light cure. Okay, so whenever you take the direction of polymerization shrinkage, so in the case of self-cure or chemical cure, the curing will occur towards the center. Whereas in the case of light cure, the curing will occur towards the light. Right? So that is one of the important concept that you have to make a note. So if you are using light, the curing will occur towards the light. And if we are using a chemical cure or self-cure, the curing will occur towards the center. So these are the basic differences between the light cure and auto cure. Auto cure is nothing but chemical cure or self-cure. So initial setting occurs close towards the light, whereas in the case of auto cure and a chemical cure, it occurs in the center of the restoration. Or a few has mentioned it as it occurs in the base of the pulp, very close to the base of the pulp. So fast setting, whenever there is a fast setting because light cure, it immediately sets with the activation of light. So there will be low flow relaxations, and that is going to lead to more stress. So that's going to lead to more stress. Whereas in this methodology, what you can do is in a light cure methodology, you can follow incremental technique that most of us, we practice it in our college. So by using incremental technique, what we are trying to do is we are trying to reduce the polymerization shrinkage. But this incremental technique is not necessary in the case of chemical cure. So clinically easy to deal, and like clinically, it's going to take a longer time. That leads to more contamination. Okay, right. I hope you're clear with the basic difference between the light cure and a chemical cure. So this diagram based question was again given in INICET. So as a revision part, I have kept it. You can see it's very easy to identify this incremental layering technique. So vertical layering is vertical technique. You can see vertical layers. Horizontal is horizontal layers. And this is cusp-like layering technique. So that is called as cuspal layering technique. And this is oblique layering technique. Okay. And this is a bulk curing where you are going to use your resin modified GIC as a liner, and followed by you're going to keep a composite and you're going to cure it. Okay, right. So packable composites or bulk composites, they comes under bulk curing property. So one of the most common complication or one of the most common post-operative consequence that we regularly see in patients going for composite restoration is what? Yes, the composite restoration is the patients will complain of polymerization shrinkage. Patient doesn't know. Micro leakage, patient doesn't know. What patient is going to tell you? The patient is going to tell you, I'm having sensitivity. So in order to prevent that sensitivity, what we can advise the patient to do? That's again a question for us. What we advise the patient to do is, you cannot use varnish whenever you're going for composite. We ask the patient, oh no, how can the patient avoid cold and hot? We ask the patient to use sensitivity toothpaste, okay, sensitive, so that the tubules which are exposed will get closed. Whenever you're going for cementation, in such condition, what you can do, you can apply varnish by which the dentinal walls or dentinal tubules can be blocked. So that is how we can do after the treatment. But before the treatment, before the composite restoration, we can take few precautions or we can keep few add-ons by which you can decrease this post-operative sensitivity. So the next question is about that. Methods to reduce the post-operative pain after composite restoration is, one is incremental layering technique. We have already discussed incremental layering technique is going to decrease the polymerization shrinkage. Second one, use of self-itch adhesive. Okay, you can use self-itch adhesive by which this post-operative complications can be reduced. Or whenever you have a deep cavities, okay, what you can do is whenever you have deep cavities, use a GIC liner or resin modified GIC liner or a flowable composite in that particular area, and followed by you go for the composite. So these are the three methods that you can practice by which you can decrease the post-operative pain sensitivity given as a consequence complete by the patient. Clear it? Very important. So textbook lines, incremental technique, use of self-itch adhesive, and deep cavities, you can use either GIC liner or a flowable composite by which you can reduce this post-operative sensitivity after the composite restoration. Clear? Okay, right. So I hope you're familiar, right? These are called as bite wings. Okay. And can you tell me which type of X-ray technique is used in bite wings, whether it is bisecting angle technique or paralleling angle technique? Yes, it is paralleling angle technique. So that is the reason why bite wings are best choice to detect proximal caries lesions. Okay. Bite wings are best choice to detect the proximal caries lesions. Morning I was discussing one question. So if you are not able to diagnose proximal caries lesions with the help of bite wings or with the help of any device, what is the last option you have? Yes, the last option you have, go for separation, whether with the help of wedge, rapid separation or slow separation. You clearly try to see it. Okay, so that is called as mechanical separation is the last mode. And similarly, when I'm explaining in the morning's voice note, I told you there should be a minimum amount of enamel demineralization should be there for a lesion to be visible on a radiograph. What is that? So the minimum enamel decalcification that is required to see it on a radiograph is 500 micrometers. So this is your NEET 2022 question. So best method for detecting the proximal caries lesions or secondary caries lesions which are present proximally is, the answer is bite wing. If you don't have bite wing, the next technique of choice for detection is you can go for paralleling angle technique also. If you check out your white and farrow, in the indications of paralleling angle technique, they have clearly mentioned it is useful in detection of proximal caries lesions and secondary caries lesions or recurrent caries lesions. That is nothing but they're following, bisecting angle is following the paralleling angle technique. So both of them can be used. The best option is bisecting angle technique only. Next, yesterday in the class, I have already discussed about uh, rule of cusp capping. So whenever your primary groove to that of the cuspal tip, if it is less than half, then there is no need of cusp capping. If it is in the range of half to 2/3, cusp capping is considered. If it is more than 2/3, cusp capping is mandatory. Okay. So enameloplasty also I have discussed yesterday. So please don't touch my screen. There is someone writing on my screen. Okay, enameloplasty we have discussed yesterday. So when do you perform enameloplasty? Up to what depth of fissure you can do enameloplasty? So yes, at up to 1/3, you can perform enameloplasty. That is basically the question. So then comes this Poisson's law. Okay, so very frequently asked formula this is. So Q is equal to P2 minus P1 r to the power of 4 pi by 8 NL. Okay, so your Q is nothing but your volume flow or volume flux, and N is nothing but the viscosity. P is nothing but P2 minus P1. So P2 is here, P1 is here. R is the radius, and L is the length. And rest everything you are familiar. Okay, right? So this is basically this concept. Basically, when I'm talking about in operative dentistry, this comes whenever I'm talking about the dentinal hypersensitivity, dentinal fluids, because there you're going to have the movement of the fluid. So most acceptable theory of dentinal hypersensitivity is, yes, the most acceptable theory is hydrodynamic theory. But already discussed, the main treatment of dentinal hypersensitivity is, how do you treat dentinal hypersensitivity? Because these dentinal tubules are open. Okay, your dentinal tubules are open. So now, because of the pressure difference, there will be fluid movement. Okay, that fluid movement is going to cause transforming this fluid movement to that of the nerve to stimulate the nerve, and the nerve is going to cause the pain. So this is what the dentinal hypersensitivity is. Okay, so you have to block the dentinal tubule. Okay, the treatment of dentinal hypersensitivity is block the dentinal tubule. Okay, most of the treatments is going to move around the sealing the dentinal tubules, except laser dentistry. Okay, whenever you can use lasers also. So lasers can also block the dentinal tubules, but rather than blocking the dentinal tubules, they are going to desensitize the nerve fibers. So whenever you have a desensitizing as the best option, go for desensitizing. If you don't find desensitizing options, whenever you're talking about a laser that helps in dentinal hypersensitivity, then I want you to go with the sealing the dentinal tubules as the second best option. Clear? So most accepted theory of caries. Most accepted theory of caries is, yes, it is acidogenic theory, also called as chemoparasitic theory. LA, most accepted theory of local anesthesia. It is specific receptor theory. And most accepted theory of most accepted theory of pain is, that is gate control theory. Then comes talking about sloping pulpal floor. So whenever you're doing a preparation, let it be a crown preparation or let it be an axis opening, preferably on mandibular first premolar. So if you check out the mandibular first premolar, so what is going to happen? There will be short lingual cusp, due to which there will be a lingual inclination of the teeth. So whenever you're doing your cavity or whenever you're doing your crown, you have to tilt your burr slightly lingually, okay, by which you can prevent the perforation or you can prevent the damage. Okay, so this is very, very specific to mandibular first premolar. Mandibular first premolar. Smallest of all the premolars is largest of all the premolars. Which is the largest? Yes, largest is max first premolar and the smallest is mandibular first premolar. Okay, right, DA part. Okay, then comes noise criteria. Already, I think like it was covered in the quick revision videos. So enamel must be supported by a sound dentin in every situation. And enamel rods, which forms the cavo surface margin, must have their inner ends rested on a sound dentin. And enamel rods forming the cavo surface angle should be covered with the restorative material. And angled cavo surface angle, your margins should be trimmed properly. So these are the 4 criteria which are given. So very, very important from examination point of view and viva point of view. Next comes is instrument classification, items classification. This comes a common topic of both the operative, endo, and microbiology, because there was an endo inclined, operative inclined question was once given in NEET examinations related to this. So critical instruments are few instruments, like particularly you see like they come in contact with the sterile tissues or the vascular system. So sterile tissue and vascular system are the one which has high risk of infection. So these are basically surgical instruments, your implants and everything which comes in contact with the blood. And the mode of sterilization is by autoclave. If it is heat stable and if it is heat sensitive, you have to use ethylene oxide or hydrogen peroxide glass plasma. Okay, right? So the mode of sterilization of critical instruments is by autoclave. Okay, right. If it is heat stable, normally if it is heat sensitive, you'll go for the other option. That is your ethylene oxide, hydrogen peroxide, and plasma. So what are the standard values of autoclave? Standard values of autoclave are the standard values of autoclave are 121 degrees centigrade, 15 minutes and 50 lbs. If they're asking flash autoclave, then your answer is 134 degrees centigrade, 3 minutes and 30 lbs. Then comes the second part, that is semi-critical instruments. The semi-critical instruments are the articles which come in contact with the mucous membrane or non-intact skin, and they require high level disinfection. The first one is sterilization. Here they require high level disinfection. So what is the high level disinfectant which is most commonly used? High level disinfectant which is most commonly used is glutaraldehyde. Even in DM, which is inclined this part, most of your impression materials will be sterilized again by glutaraldehyde. We have discussed about this also in the DM smart video, in DM quick revision video. So please do look into that. So glutaraldehyde. But best skin disinfectant is it is powdered iodine. How much percentage? Yesterday we have discussed on the group. Yes, right. That is 10%. Glutaraldehyde, how much percentage is regularly used for disinfection? 2% of glutaraldehyde, which is called as 2% of glut, which is called as Sidex. So your endoscopies, bronchoscopies comes under high level of disinfection between patient to patient. The next one, non-critical instruments, which come in contact with the intact skin, but not the mucous membrane. Examples of bed pads, blood pressure cuffs, and everything, all these are going to come under low level of disinfection. Okay, so I hope this is very, very clear. Then next comes is a very frequently question which is coming from from 1 to 2 decades, very frequently asked question. Even in the latest 2022 examination, the question was given. Anti-rust solution that is used is sodium nitrite. Okay, right? Sodium nitrite. Ice will be there. Okay. Normally, burrs are sterilized by, how do you sterilize your burrs in your college? How do you sterilize the burrs in your college? Autoclave. Next comes is preventive resin restoration, also called as conservative adhesive restoration. It is indicated in the teeth with a minimal teeth and fissure decay. So whenever you have a minimal decay, okay, we regularly go for this preventive resin restoration. Very frequent nowadays. I don't know why they're asking, because it's of course inclined to both operative pedo as well as community preventive dentistry part. So whenever you have a minimal fissure decay, so the restoration that we regularly go for is preventive resin restoration. It is a minimal cavity preparation that is required to prevent the unnecessary removal of the healthy tooth structure for retention purpose, like what we do previously in the amalgam. If the decay is limited to the enamel, then there is no need of local anesthesia. After etching, rinsing, drying the cavity and condensing with a normal composite or a GIC, by which the restoration can be done. And types of preventive resin restorations is based upon the extent and the depth of the caries lesion. For example, type A. So you have pit and fissures where the caries removal is limited to enamel. That is your A. The second one is type B. There is caries in the enamel and initial caries lesion in the dentin, which is confined and small. That is called as type B. E and superficial D. And category 3 is greater depths of preparation and dentin is required. So enamel and deep in dentin, that is called as type C. So A, B, C are again important. Diagram based question was asked in 2023 examination. Similarly, Simonson has been divided the sealants which are used for filling this into again type A, type B and type C. Type A is unfilled sealants which are going to have more flow properties. And type B is dilute. Dilute is a combination of unfilled and filled. And type C is filled. So here they have given diluted composite resin is a mix of filled composite resin and unfilled bonding agent. Okay, so it's a combination of filled and unfilled. Right. So that is all about like types of resin restoration. That is type A, type B, and type C. And this is what the question that is given already discussed. A, confined to enamel. B is confined to enamel and initial dentin, and C is deep into dentin. So this was the question that is given in 2023 NEET examination. So they have given the same diagram and they asked us to identify the color coding. Okay, simple, very simple. They asked us to identify color coding. They have given it as A, B, and C. So can you tell me what is A, B, and C? Yesterday we have discussed in the WhatsApp. So what is A, B, and C? A is sealant. B is composite. And C is base. Nice, done. So then I just want to jump into prophylactic odontotomy, which is given by Hayat. And so basically, the concept is very simple that your first molars are more prone to dental caries. So anyway, it is being affected by dental caries and we are going for a restoration. So what they have done is, once these first molars erupts into the oral cavity, so they have removed that superficial fissure and pit area and they have filled with oxyphosphate cement initially. And later, after a few days, once everything is settled down, they have replaced this oxyphosphate cement by amalgam restoration. This is what basically happened, right? So they can ask you, which of the following cement is used in this prophylactic odontotomy procedure done by Hayat long back? Your answer is oxyphosphate cement. And final restoration that is used in this prophylactic odontotomy is amalgam again. Fissure eradication technique was given by Bodecker. And similarly, you have Bisgema. Bisgema was developed by Bowen, and similar Bowen is also associated with the Gatabacha. Okay, both are different, but name-wise they are same. Okay, so Bowen is basically responsible for both Bisgema as well as Gatabacha. Okay, right. So then about wedges, most of you are familiar about the wedges. Wedges are the devices which are usually preferred for rapid tooth separation. Okay. And wedging techniques are very, very frequently asked questions. So many times repeated in the last 5 years of NEET, particularly rather than INICET. So wedge wedging is a technique where two wedges are used 90 degrees to each other. You can see a diagram based question is also given in the exam. So please do be focus on the diagrams also. So one wedge is inserted from the lingual embrasure area while the other wedge is inserted between the wedge and the matrix at right angle to that of the first wedge. So wedging means you are wedging the wedge. So that is called as wedge wedging. So these are primarily indicated where you are going to do this. These are primarily indicated in MO. These are primarily indicated in the MO of maxillary first premolar. So because of the fluids on the root near the gingival area. The next comes is double wedging. Here two wedges, one wedge from the buccal embrasure and other wedge from the lingual embrasure. The angle between the two wedges is 180 degrees. So this technique is used in the cases where single wedge is not sufficient to fill the space. So that is widen proximal box buccolingually is a special case where you have to use double wedging technique. Double wedging is a case where single wedge is not sufficient. Then comes the piggyback. In this technique, two wedges are used. They are of different dimensions. One is the larger wedge, which is inserted normally, while a smaller wedge is piggybacked above the larger wedge. It is regularly used in the cases of gingival recession. Okay, then I want to jump into types of pit and fissure sealants. The code what I have given is universally Sachin is very famous. Universally Sachin is very famous. U for UV light. That is your type 1. Sachin, S for self-cure. That is type 2. Very, V for visible light. That is type 3. Famous is fluorides, fluoride release. That is your type 4. In the last couple of years, question which was repeated 3 times is type 4 pit and fissure sealant is. Type 4 pit and fissure sealant is, what is your answer? Fluoride release. Okay, a little bit about pulpal necrosis. Can you tell me what is the pulpal pressure in pulpal necrosis? Whenever there is a pulp necrosis, what is the pulpal pressure? So 0. Okay. See, so whenever the pulp is dead, there is no pressure in the pulp. Okay, pulp is dead. The patient is dead. What is the blood pressure in the patient? Blood pressure in the dead patient is 0. Blood pressure in the dead pulp is 0. Very simple. Okay, right. So, which Ellis classification or class is inclined to necrotic pulp? Yes, perfect. Class 4. Which crown preparation can lead to necrosis? You have different types of crown preparation, like 7/8 crown preparation, 3/4 crown preparation. Okay. So which is basically involving the more surface area of preparation that is more inclined to necrosis. That is full crown. Which class of GB blacks is very close to pulp? Which class of GB blacks is very close to pulp? Yes, very good. Class 5 is very close to pulp. Any idea about strangulation pulpitis? Where do you see strangulation pulpitis? Yes, strangulation pulpitis is seen in class 5 plus calcium hydroxide. So whenever you keep calcium hydroxide very close to pulp in a restorations like a class 5, there is a type of pulpitis that is called as strangulation pulpitis. Means this calcium hydroxide is going to decrease. It's going to decrease the blood supply to the pulp in that particular area. That is called as strangulation pulpitis. Okay. Okay, nice. OSHA full form. DM inclined to operative. OSHA full form is Occupational Safety Health Administration. Okay, Occupational Safety Health Administration. According to OSHA, okay, the amount of nickel that is permitted is 1 gram, 1 milligram or 0.1%. Okay, in an 8 hours exposure. Okay, and very important aspects that we need to make a notice. Metal which is causing more allergic reactions in dentistry is, or dental metal which is causing more allergic reactions is, yes, it is right. The answer is nickel. And apart from this, nickel is again carcinogenic also. So metal which is causing more allergic reactions in dentistry is nickel. Can anyone tell me what is the test that is used to find out the allergy of the nickel? Normally, what is the test that is regularly used for allergies? Allergy test is patch test. Very good. For nickel, specifically for nickel, Pater test. Pathergy test is useful for? Yes, pathergy test is useful for Behcet syndrome, oral pathology. Okay, right, perfectly right. So most common material causing allergy in dentistry. Most common material causing allergy in dentistry is latex. Very good. The most common material which is causing allergy in dentistry is latex. Most common metal which is causing allergy in dentistry is nickel. Most common type of allergies in the dentistry is type 4. Very good. What is type 1 allergy? Normally, what is type 1 allergy? Type 1 is anaphylaxis atopy. Dangerous, immediate, dangerous. And what is the drug of choice for this? Adrenaline, I want ratio. Those days are over. Okay. Adrenaline is over. Now, Gayatri, it's not IV. You cannot give IV. Yes, it is 1:1000 IM. 1:1000 IM is the 1:1000 IM. Adrenaline is the drug of choice for anaphylaxis. Very nice. Right. So type 4 are the most common in dentistry. In some cases, you see type 1 also, which are very, very dangerous. So mercury and amalgam poison, amalgam allergy is type 4 allergy. Can you tell me what is the value of density of mercury? Value of density of mercury. Acid is 14 times heavier than water. Yes, 13.4 is the best answer. So melting point is minus 38.6 degrees. ADS specification number of amalgam? Yeah, fine. 1. Mercury? Mercury is 6. GIC? Not 46. Not 25. 25 is again a very important ADS specification number. Anyone? ADS specification number of GIC? 66. Okay, then comes 400 times the maximum accepted levels, very important. I'm talking a few lines about mercury. Can anyone tell me what is the half-life of mercury? Half-life value of mercury. Very good, 55 days. Lifespan of RBC? 120 days. Platelets? 7 to 10 days. So make sure the creep value of amalgam should always be less than 3%. Is a again a frequently asked question. So these are few numbers related to the mercury. So please do make a note of it. If you don't know, all these are present in your PP books. Very important previous repeats. Occupational safety level of mercury is 50 micrograms per mm cube. Threshold value of mercury in mercury industry is 350 to 500 milligrams per day. 65 to 85% of inhaled mercury vapor is retained in the body, which is the most dangerous form of mercury. Most dangerous form of mercury. Organic. That is basically methyl ethyl. Methyl form is the most dangerous organic form. And accepted urinary levels are 15 milligrams per liter and accepted blood levels are 4 nanograms per ml. Earliest sign can be seen when your urinary levels are 30 milligrams per ml and your blood levels are 35 nanograms per ml. Okay, all these numbers are very, very important. So please do make a note of it. And I hope you know, you are familiar about the chair positions. Universal chair position is? says universal chair position is, okay, right rear position, 11 o'clock. Right rear position is 11 o'clock. For a left-hander, it will be left rear. Okay, for right-hander, it is right rear. And direct rear is 12 o'clock. Direct right position is 9 o'clock. Direct front position is 7 o'clock. So I hope you are familiar with this, familiar with these things. Okay. So then I'm jumping into pins. So what is the primary purpose of giving a pins in amalgam registration? That is pin retained amalgam registrations. So the primary purpose is to increase the retention. But what I'm doing is, instead of increasing the retention on one side, I'm trying to decrease the strength of amalgam on other side. Okay. Particularly this TMS pins are very, very important. They're color coding and everything. So one is regular. My code is regular. Regularly, Indians wear. What Indians wear regularly? Whenever you go for marriages. So regularly, Indians wear gold. Okay. Mini, at least minimum what they wear? Minimum what they wear? Yes, minimum we wear silver. Minimum we wear silver. Regularly we wear gold. And second one is mini kin. Kin, K for king, king for Kohli. Kohli belongs to which group, which team? Yes, RCB, red. Nut, you can remember, nut is pink in color. Okay, so this is very important. Nowadays, we don't find much questions on these concepts, but long back, best choice to give a tough question is these areas. So jumping into the types of pins, one is self-threaded. Self-threaded means the pin is going to have threads on it. Okay. So these threads are basically useful for the retention. How they obtain the retention? These threads are going to thread into the dentin. So they obtain retention by the resiliency property of the dentin. Okay. And these are the most retentive pins. These are the most retentive pins. Next one, I want you to make a note about the diameters and everything. So the pinhole is 0.0015 to 0.004 inches smaller than the diameter of the pin. Thereby, it is going to gain the resiliency retention property from the dentin. As it is screwing into the dentin to get the retention, these are going to cause maximum grazings in the dentin, means micro cracks in the dentin can be visible. The pin should be 2 millimeters into the dentin and 2 millimeters into the amalgam. Okay, so in amalgam, it should be 2 millimeters. In dentin, it should be the 2 millimeters. Clear? So these are most retentive pins. As they are more retentive, they are getting the resiliency property from the dentin. As they are more retentive, they are causing the maximum micro cracks in the dentin. Next, cemented pins. Cemented pins, the mode of retention is by the word itself is telling the mode of retention is by luting cement. So these are less retentive. They don't produce cracks in dentin. So they extend 3 millimeters into the dentin and 2 millimeters into the amalgam. The pinhole here is larger. There it is smaller. And these are most commonly used in non-vital teeth because you need to screw them inside, right? Screw them inside and lute the cement and everything. So these are most commonly used in non-vital teeth. Then comes the friction lock cementum. They also obtain retention by friction. Okay. So these are intermediate retention. They produces cracks in the dentin, but not as heavy as friction lock. So not as heavy as self-threaded. And they are screwed 3 millimeters into the dentin, 3 millimeters into the amalgam. These are also smaller when compared to the diameter of the pin, and they get retention by resiliency of the dentin. So retention by resiliency of the dentin is for which type of pins? Retention by resiliency of the dentin is for which type of pins? One is the first one, self-threaded. Second one is the friction lock. Retention by luting cement is for cemented pins. Which type of these three produces least cracks, less grazing? Cemented. Maximum. Less is cemented. Maximum is self-threaded. Few other lines which are taken from your PP books. So they can ask you diagram based question also. Self-threaded 2-2, cemented 2-3, friction lock 3-3. All we have discussed. And pins should not be close than 0.5 to 1 millimeter to DEJ and should not be closer than 1 to 1.5 millimeter from the external surface and should be surrounded by at least 2 millimeters of the dentin. And should be into 2 millimeters of the dentin. You see, this is 2 millimeters, this is 3 millimeters, this is 3 millimeters. And 1 millimeter thickness of surrounding dentin should be present. The minimal thickness is 1 millimeter to be present. I just want to link this concept to your post and core concept. So post and core also we have discussed there are three principles. What are the three principles? Three principles of diameter of post and core. Preservation, proportion, conservation. So there also the concept clearly says you should preserve at least how much millimeters of dentin? Yes, you should preserve at least 1 millimeter of dentin. Less than 1 millimeter is so dangerous. Same goes here. So the same concept in post and core also. Okay, so what is the purpose of post? What is the purpose of post in post and core? Yes, the purpose of post in post and core is retention of core. Okay, so guys, again, this is one more table, very important table, star table, okay, which was prepared by me from PP books. Okay, hell number of questions from this table. Okay, right. So trust me, more than 5 to 6 questions were given in the last 5 years of NEET and INICET from this particular table. Okay, so yesterday we have already discussed. So this was given in NEET 2023. Yesterday we have discussed 2023 and 22 NEET, right? So this question was given twice. So what is the bevel, gingival bevel that is given in the case of amalgam is 15 to 20. So if it is in the case of inlay, what is the bevel that is given? Bevel that we give is 30 to 40. Butt joint, we're going to give as a KO surface in the case of amalgam. Composite on root is also butt joint. Amalgam, silicate, porcelain, composite on root surface. So what is the KO surface angle? The KO surface angle is butt joint, which is 90 degrees. So what is the KO surface angle in the case of composite? Preferably more than 90 degrees. In the case of inlay, it is few areas it is given as 130 to 140, few areas it is given as 140 to 150. Okay. Occlusal bevels or functional cusp beveling regularly we have discussed, right? Occlusal bevels or functional cusp beveling we have discussed in FPD and everything, that is 45 degrees. Any brushing technique very specifically 45 degrees? Brushing technique specifically 45 degrees? Yes, Bass method. Tunnel preparation angle of burr is? Yes, tunnel preparation, the angle of burr is again 45 degrees. Right. Okay, so I'm done with this. So now I just want to jump into preventive part. Okay, so preventive, we have discussed pit and fissure, we have discussed preventive resin restorations, and remineralization is one of the very, very common topic that the questions can come from. Okay, so I told you, like, whenever you have a white spot lesion, so what is the treatment of a white spot lesion? The treatment of a white spot lesion is, it is remineralization. So one most commonly used remineralizing agent that we are familiar is fluorides. Okay, so please don't miss fluorides. Fluorides are very, very important. Community pedo operative. Fluorides are damn important. So don't miss fluoride smart video that is available for you, or you try to check out the PP books content of fluorides. Fluorides is very, very important. So don't miss fluorides. Again, of course, I'll be adding few more fluorides in pedo part of bootcamp series also. So apart from fluorides, other media where you can where they can be remineralization is best media where remineralization can be done is saliva. Second one is you can use fluorides because fluorides are present in the regular toothpaste and everything. Fluorides can be done. The third one is the third ingredient, which is nowadays very trendy, very commonly used in dentistry, is what is that? Of course, xylitol is also there in the list. Xylitol, I'm going to add fourth. Okay, that is CPP ACP. Okay, CPP ACP. So first of all, we'll try to look into xylitol. Questions which are frequently repeated in the exam are number of carbons, 5 carbon sugar alcohol. 5 carbon sugar alcohol. It has an inhibitory effect on the Streptococcus mutant and reduces the lactic acid production in the dental plaque and resulting in high plaque pH. So normally what is going to happen? Your carbohydrates get accumulated over a period of time. There is a process that takes place and this process is going to release lactic acid, and this lactic acid is mixed with saliva and thereby changing the pH of saliva, hitting it to a critical pH. Normally the pH of saliva will be around 6.7 to 7.2 with a little bit of variations which we have discussed in dental histology. And now whenever the this value hits the critical pH, what is the critical pH? So what is the critical pH value? Yes, critical pH value, again, a frequently asked question, 5.2 to 5.5. So whenever it hits the critical pH, is lactic acid, the teeth is going to lose its calcium and phosphorus. That is called as demineralization. So you check out this particular line where questions are very frequently asked on this particular line. What is this line? You check out this line, the last line. Xylitol carries calcium into initial white spot lesion that helps in remineralizing the white spot lesion. That is what the treatment for a white spot lesion. A white spot lesion has to be remineralized. We don't prepare a cavity on a white spot lesion. Then comes, this is all about xylitol. I want to jump into next part, that is CPP ACP. Casein amorphous calcium phosphide. So that is available as recaldent. Chewing gums are also available. MI paste is there. Even if they're talking about MI paste, or even they're talking about recaldent or GC tooth mousy. So these are the three familiar brand names for CPP ACP. So whenever you see these things, first of all, it hits your brain should be a remineralizing agent. Okay. So what is this? This is a protein nanotechnology. Casein, C for casein. Casein is which product? Yes, casein is basically obtained from milk. Casein is basically obtained from milk, and this is produced by, this is initially the research work is done by Australians in Melbourne University, and the person who is mainly responsible is Eric Reynolds. Eric Reynolds is the person who is responsible for this CPP ACP. Okay, right? So these are the important things. And they can ask you ammono acid sequence that is present in CPP ACP is ser, glut. Okay, so please do make a note of this ammono acid sequence because we are talking about it's a protein nanotechnology. So proteins are regularly a group of amino acids. So this is a amino acid sequence for CPP ACP, which is a very, very star point to be added. They can ask such bouncers in the exam. Now CPP ACP is done. So there is something called a CPP ACP. What is this P? P for plus means you are adding something. So I told you right previously we started the journey with the beauty of fluoride. So now what I'm doing is CPP ACP is not having fluoride. So what I'm doing is I'm adding fluoride. How much amount of fluoride I'm adding? Important. This is again a question for you. How much amount of fluoride is being added in CPP ACP? 0.2% of NaF, which is 900 ppm is being added. Right. So what happens is whenever you have, that hydroxyapatite crystals are there, they reacts with fluoride to form fluorohydroxyapatite or fluorapatite crystals will be formed. So if you check out the size of this normal hydroxyapatite to fluorohydroxyapatite, the crystal sizes are large. So large size crystals, and these are more resistance to caries. Sorry, more resistance to, yes, caries and acid dissolution. Normally, what is the critical pH of a normal hydroxyapatite? The critical pH of normal hydroxyapatite we have discussed, that is 5.2 to 5.5. So critical pH of fluorohydroxyapatite is, yes, it is 4 point, means the salivary pH has to hit 4.2 to 4.5. Then after which the dissolution starts if a hydroxyapatite is treated with the fluoride. So that is the concept of fluorohydroxyapatite. So that's what they have given here. Okay. So the major mineral form during remineralization with the use of CPP, ACP is fluoroapatite, which is resistance to acid attack when compared to the normal hydroxyapatite because of increasing in the size and because of more resistance to acid. Clear? Clear, clear. Okay. So I was talking about mid, right? So what is this mid? Mid is nothing but, so mid is nothing but minimal invasive dentistry. Okay. So most of these, whatever we have discussed are going to come under mid. All the preventive stuff will be a part of mid. Your chemomechanical remove, your air abrasive remove of caries lesions, your tunnel preparations, your slot preparations, all these minimalistic things will be coming under mid. And mid, who is the father of mid? Yes, father of mid is Mount. And we have discussed in the quick revision video also, we have discussed a classification called as Mount's classification. What is Mount's classification? Yes, it is called as site and size classification. It is going to have two numbers. The one number is going to tell you about the site and the second number is going to tell you about the size. That is called as Mount's classification. So hope you go back and check the quick revision videos. I mean, like, you have to be perfect with GV blacks. You have to be perfect with Mount. You have to be perfect with all the classifications related to the dental caries, particularly ICDAS classification and everything. So now I'm jumping into the chemomechanical caries removal. So what is this chemomechanical? What do you know about chemomechanical? Yes, Carisol, Caridex are the main target areas as a UG student for you. Okay, but one more Papa Caries also added. So it is basically you're going to dissolve the caries lesion, and by the softened dentin is going to be removed. So that is called as chemomechanical. So the need of local anesthesia is reduced, and in most of the situations, it is completely eliminated. So if you jump in and if you see, this comparison table is very, very important for chemomechanical removal of dental caries. So I have already said, first one is Caridex, second one is Carisol, and third one is Papakeri. And make sure the only thing I want to add on is Caridex is liquid. Sol means don't think it's a solution. It is a gel. Okay, right? So Caridex is liquid and rest two are available in the gel forms. Okay, so don't get confused. The only confusion area is people will think Sol is a liquid. Okay, but it's not. Because Carisol is gel. Okay. The next, everything you have n number of questions. If you solve dental pulse or previous questions, you see n number of questions on this area. Particularly, I was talking yesterday, I was talking about NaOCl, right? I was talking when I was talking about disinfection, NaOCl. So what is the percentage of NaOCl used in endo? I've discussed everything in a uh, long voice note. 2.5 to 5.2% is very good. According to Engel, with the mention according to Engel clearly, your answer should be 6%. Revascularization endodontics. Revascularization endodontics, you have to use less percentage because it's going to kill the periapical stem cells, 1.5%. Dakin solution. Dakins, yes, Dakins again 0.5. COVID tunnels, it ranges from 0.5 to 1%. Right. Again, you see NaOCl fellows coming here. Okay. So 1% of NaOCl is used in the case of Caridex and 0.5% of NaOCl is used in the Carisol. And similarly, very frequently asked questions is the ammonia acids which are present in all of these. Okay. The solution 2. Solution 2 is going to contain ammonia acids. So ammonia acids are very, very important. Ammonobutyric acid and glycine are present in the case of Caridex. Glutamic acid, leucine, lysine are present in the case of Carisol. and endoproteins are present in the case of Papa Carey are very, very important. So, and next one is dye is absent in the case of Carydex, whereas dye, the most commonly used dye in the dentistry is etrosine, which is present in the case of Carysol, and Tolidin blue. Tolidin blue. Any other use that the Tolidin blue is having? Oral path? Tolidin blue? Yes, Tolidin blue. Yes, right, Akshit, very good. So Tolidin blue helps in identifying the cancer lesions, cancer cells. Okay. And coming to the pH is 11 for all. Okay, the pH is 11 for all. Anything you have learned pH of 11? Yes, calcium hydroxide 11. Just before the class, someone is asking about MTA pH. Initial pH of MTA. Initial pH is 10.4. Fresh prepared 10.4. Final set 12.4. Setting time of MTA. 165 minutes. Then so check out the last line. The last lines are not much important, not given in the exam till the date, but I don't assure you that the questions will not come from. Okay, so they can ask you preparation remains active after mix. It will be remain active for 1 hour. So Carey Sol remains active for 20 minutes, and Papa Carey does not require any sort of mixing and don't require any special instruments for its application. Okay, right? So that's all about chemomechanical removal of dental caries. And I just want to add a note. There's something like a green color burrs. Diagram based question was given. Green color wala burr. What is that green color burr? Yes, covered in your smart videos. So green color burr is called as smart burr. So what is the advantage of smart burr? Yes, smart burr will remove only the infected dentin and will not touch the affected dentin. Okay, so that is means a burr. The strength of the burr is only sufficient to remove the infected dentin part and will not touch the affected dentin part is called as a smart burr. It's something like in a piezoelectric unit. Okay, what is the advantage of a piezoelectric unit? The frequency of a piezoelectric unit will affect only the hard tissues and will not damage any soft tissues which are close to it. So that is the reason why we use this piezoelectric. Okay, right. Similarly, this is only removing the infected dentin but not affecting the it is only removing the infected dentin but not affecting the affected dentin. So that is the advantage of the smart burr. How many times you can use the same smart burr? Is it used only once? Once you use it, you have to throw it, or you can use for multiple times. It has to be used only once. Most of the things in dentistry, we have to use it in once, but in India, we don't. We use it for a number of times. Okay, right. So critical pH, I have discussed a lot about critical pH. Okay, right. I hope like you're familiar with the Stephen's curve. Started the journey of Stephen's curve in your oral pathology. Okay, the curve, I mean, like they'll mention it as time after the glucose rinse versus salivary pH or plaque pH. This is how the curve is going to be. Okay, very frequently asked either in diagram based format or in other formats. The important points that I want you to make a note from Stephen's curve is the type of electrodes which are used in Stephen's curve. What are the type of electrodes which are used in Stephen's curve? The type of electrodes that are used in Stephen's curve is antimony electrodes. Caries free, you're familiar that the pH is going to be around 7. In the caries prone individuals, it is critical pH that is 5.2 to 5.5. Very commonly repeated, so many times given in the exam. The pH drop, anterior maxilla exhibits more pH drop than the anterior mandible. The pH drop will be more in the maxilla when compared to that of the mandible. There is one more curve. Question was given in the SRC papers, okay, for operative dentistry people. Starloff's curve, which is a combination of Stephen's curve plus lactobacillus count. Okay, so we have already discussed what is the critical pH of enamel. Critical pH of enamel. Enamel start dissolving 5.2 to 5.5. Enamel with fluoride 4.2 to 4.5. Critical pH of dentin. Yes, you can make it as 6 or 6.2 to 6.5. For easy to remember, I told you this 6.2 to 6.5, 7.2 to 7.5. Normally it is 6, it is 7. Okay, right? Cementum. I mean, the critical pH of cementum is around 7. Critical pH of dentin is around 6. Critical pH of enamel is around 5. And critical pH of enamel treated with fluoride is around 4. That is 4.2 to 4.5. Clear, guys? Hope you're done with the Carey's activity tests. Okay, so Carey's activity tests, the best source to read is Shobhan Peter. A well-organized notes was prepared and given in your PP books part, and it will be present in your PP books volume 5 community part. It is given in the community part. If you're not done, please go back and please try to do it. Okay, right? So I think I no need to explain this. Okay. So Cinder tests the rate of color change after the incubation. So if the color change occurs in the first 24 hours, that is called as marked Carey's activity. It occurs in 24 to 48 hours. It is moderate Carey's activity because these questions were given in the exam. Color change occurs after 2 days, that is 48 to 72 hours, slight Carey's activity. No color change even after 72 hours, that is after 3 days, that is negative Carey's activity. There are two types of interference which are given for Cinder test. This is one. Okay, so both of them were given in the exams in different exams. The concern here is we don't know where the paper setter is basically taking the reference. Okay, so normal way of preparing a question paper is, I mean, I'm just telling with my experience of observing so many question papers from last 10 years. Okay, so what paper setters they do is, it is a mandatory for a paper setter to code the reference. Means whatever question he prepared, let it be an application question, let it be a direct question, let it be a diagram based question, he has to code the reference. Means he has to code a perfect reference. So keeping this in mind, most of the paper setters in India who are going to prepare a question paper will take references from the standard textbooks, or one is references from the best standard textbook. Second one is reference from the standard textbook which they love. Okay, for example, you talk about myself. For example, if you are asking me to prepare a question paper, so I love to pick from the most standard textbook. For example, if it is an oral pathology, I'll try to pick from Schaffer's. If it is operative dentistry, I love to pick from Students. Or if it is from endo, I may pick Engel, which I like compared to the Grossman or something like. Normally standard is they can pick whatever. For example, if you are giving to someone who is a textbook author, okay, and asked to prepare a question, he is going to consider his textbook as a standard. So it is not mandatory, but most of the questions will move around the standard references. So it's mandatory that the paper setter has to keep a question from a source which is already there. It is standard. Randomly, he cannot prepare a question. So reference is mandatory. So keeping this in mind, one type of question making is, so they check the previous questions from different sources of books that are available. For example, an intern is there in the department where a HOD or some professor has got a letter from NBE to prepare few questions. So what he is going to do, he is going to ask the intern to get the dental pulse or whatever book they are reading, and they are going to check it, and they may pick some questions from that particular book. But along with the questions, they are going to take the reference also. Like in most of the books, you have references, right? So this is taken from this edition, 5th page, and this page edition reference is there. So in most of the situations, what they do, they cross-check it and they're going to give some repeats also. If not, whenever they want to prepare a new question, the new question will be from the standard reference Preferably in 90% of cases, it will be from the standard textbook, regular standard textbooks, what the dentists are going to follow. Sometimes the 10% of candidates, they prefer to go with the textbook, what they love, what they prefer. Got it, right? This is how it's going to be. You see like questions, you see like new questions are coming, you find the new questions, because my purpose is always to find the questions where they're coming from, which source they're coming from. You check out here and there, you check 2 or 3 textbooks, you find out the same line which was given by the paper setter. We feel that's a new question, but it's basically from the textbook. Okay, clear, right? Similarly, you have different types of caries activity tests, but in this, I'm just stressing out only 2 tests because the second test is again a very frequently asked question. Okay, reductase, salivary reductase test. I hope like few of you have solved n number of questions. Can you tell me which color was given so many times in INICET till the date? Yes, it is orchid. This orchid was given. So whenever the color change occurs within 15 minutes, normally the color changes occurs within 15 minutes. Sometimes the color change can occur immediately. So blue color 15 minutes, non. Orchid 15 minutes, slightly. Red color 15 minutes, moderate. Red colors immediately, high. Pink or white color immediately is extreme. So in pins, what is pink color? Amalgam pins, what is pink color? I told you to remember. Yes, I told you to remember nut. I told you to remember nut. Very good. Okay, so I'm jumping from this part. Again, this is taken from students. There are few controversial numbers which are overlapping from your regular Schopenpeter. So I just try to mop those numbers. So let's focus on what are important, okay, rather than overlapping concepts will lead to more confusions. So I think like most of you are familiar about water fluoridation, right? So what is the amount of fluoride that is present in the public water fluoridation? So water fluoridation is 2 types. One is public water, second one is school water. Yes, I want you to go with an option around no 0.7 to 1.2 concept is very old concept according to Schopenpeter. Now 0.7 to 1.2 we are not using. We are preferably using 0.5 to 1. Okay, that is your public water fluoridation. Can you tell me what is school water fluoridation? School water fluoridation is 4 to 6 times. 4 to 6 ppm I want you to go with. And the next one is I want you to focus on amount of fluoride in dentifrice. Amount of fluoride in dentifrice. Schopenpeter is telling around like 900 to 1000. You can go with this value also, 1000 to 1500, 1000 to 1450. Prescribed strengthening fluoride dentifrice, if they're asking, means targeting only fluoride, it's going to have more, that is 5000, around 4950. 1.23% of APF gel, ppm is 12,300. And of course, we have discussed about this SDF. SDF, what is the percentage? Yes, right, 38%. 38%, it is 44,800. And SDF is the applicant of choice in cavitated caries lesions. And it can be used in the root caries also. That's what we are going to discuss now. So these are the values I want you to make a note. And caries reduction is maximum with community water fluoridation. Okay, caries reduction is maximum with community water fluoridation. Again, a very, very frequently asked question. Guys, clear, right? 44,800 ppm for SDF, 38% is SDF, 8% of SNF2, 1.23% of APF gel, 2% of NAF, and APF gel 1.23% turns around 12,300. Professional strengthened fluoride dentifrice is 4,950. Normal dentifrice is 1,000 to 1,450. School water fluoridation community water fluoridation, the basic questions. The caries reduction is more with community water fluoridation. So I told you, right, SDF. SDF is very important, trending topic in the last 5 years of NEET and INICET. So let's read whatever that is given in the textbook. So SDF is a topical solution used as a caries arresting and anti-hypersensitivity agent. So it not only stops caries, it also can be used as a dentinal hypersensitivity agent. Okay, so what is that? Okay, both silver and fluoride plays an important role in their mechanism of arresting the caries and treating the tooth hypersensitivity. We have discussed that. What are the ingredients which are present? I have discussed in the previous slide. One is it is going to contain silver, it's going to contain ammonia, and it's going to contain fluoride. So fluoride and silver, what is the purpose of fluoride and silver? They helps in arresting the dental caries and they helps in treating the hypersensitivity. And I already told silver acts as antibacterial action and it slows down the demineralization and enhance the remineralization. This is not only the purpose of silver, the same purpose for which fluorides are used, the same purpose with which xylitol chewing gum is used. All of them, they demineralize, they reduces the demineralization and they enhances the remineralization. And that is the reason why, so in arrested large caries lesions also, you can use this. The main drawback of SDF, silver main drawback is, silver is going to cause precipitation. Whenever there is a silver, the silver is going to cause black color stain. So the main disadvantage of SDF, like they can give a, this question is also given, staining. So after application of which of the following fluoride tropical agent, they have given a very discolored teeth to the particular patient, and they have asked probably which of the following fluoride tropical agent can be used in this patient is SDF, because the most main important drawback of SDF is precipitation of silver leading to black color. And this can also be effective in preventing the root caries. I told you it can be used in dental hypersensitivity. It can be used in cavitated lesions. It will prevent the caries and it prevents the root caries lesions also. So next one is application of SDF only requires the removal of the biofilm and the application of the product with micro brush for about 3 minutes. And then rinsing the area with water and covering that lesion, the lesion with the fluoride varnish. And care should be taken that the gingival tissue, lip tissue should be covered with petroleum jelly because it may cause staining. Points to be remembered. I want you to add to this point. It has been reported that 50% of arrested lesions were reactivated by 24 hours after one application of SDF. Means it was stopped, but after the uses, it was again reattacked. Okay, clear, right? Clear, right? Overall glance about SDF. What is SMART? SMART. SMART is a combination of SDF plus GIC. Sandwich is a combination of sandwich technique is a combination of GIC and composite. GIC and amalgam. Type 2 GIC and amalgam is called as miracle mix. GIC plus resin is called as modified GI, resin modified GIC. Okay, we'll discuss all those things. Okay, so it is resin modified GIC. Agar alginate, agar plus alginate technique is called as, that is called as laminate technique. Okay, then comes the classification of composites, already discussed, so I don't want to touch. There are two very important types of classifications. Okay, one is traditional classification. Second one is this classification: macrofilled, midfilled, minifilled, microfilled, nanofilled, and everything. So I want you to make a note. Along with this, as there was a question that is given in the 2024 NEET, which I have kept in front of you. So this classification wala question was taken from the most confusing overlapped classification, which is there in the present edition of Dental Phillips, which was posted yesterday in your WhatsApp groups. If you want, you can check out that classification, but that leads to more confusion. So what is the question that is given in the exam is small particle filled composites comes under. Okay, so in the brackets in the textbook, it was mentioned as mini filled. Okay, so I want you to go with the mini filled as an answer. Normally, hybrid composites. What are these hybrid composites? Hybrid composites. Hybrid. What is basic meaning of hybrid? What is the basic meaning of hybrid? The basic meaning of hybrid is mix of two or more. So whenever hybrid is there, the hybrid is going to have microfilled with other filler sizes. Like multiple filler sizes comes under hybrid. One of the filler size is going to be microfilled. The other filler size can be large filled, mid filled, or mini filled. So in the description part, in the mini filled, they have mentioned mini filled can also be called as small particle filled composites. In the descriptive textbook, it was given like that. So I want you to go with the mini as an answer. Mini filled for that. If mini filled is not there in the options, okay, then the second best option can be hybrid. Okay. Because you have all these variations of questions in different books. Yesterday I was checking triplet or something. Triplet has given hybrid as an answer. Okay. So basically mini is the best option. If you don't find mini, then I want you to jump into hybrid. Clear? No confusions? Because now it is a media, social media, you have multiple questions coming from different sources. Your friend is going to post some PDF. The seniors are going to post some PDF, but please try to follow MDS CONQUER, leads to less confusions. Okay, then jumping into the next part, restorative materials. Again, this table was taken from your Power Play books, radiology part. Notes was prepared by me when I was doing my internship. It was prepared by me. So restorative materials on radiograph, how they look like. Okay, so that's very important concept. The radiographic appearance of various restorative materials depends upon the following properties. One is thickness of restorative material that is used. Second one is the density. We have density values, right? So density values. Third one is atomic number. So basing upon these three features of particular restorative material, their radiographic appearance can be determined. Now jumping into the lines which are given in the textbook, acrylic will appear radiolucent. Silver amalgam, most of you are familiar. You have seen silver amalgam on radiograph. So silver amalgam, gold, stainless steel, gutta-percha, silver points. How do MTA look on a radiograph? How do MTA look on a radiograph? Because MTA is having radio opacifiers. Gutta-percha is having radio opacifiers. The main motto of adding opacifiers, they have to look radio opaque. Okay, right? So these are the main things that I want you to focus on. Okay. So radiolucent, this is calcium hydroxide. Sometimes it is radiolucent, sometimes it is radio opaque. Silicates are radiolucent. They may not ask. Again, composites basing upon the composition, it can be a radiolucent or a radio opaque. Porcelain is radiolucent. Okay. Diamond is radiolucent. GIC, a big question mark. According to dental materials classification, it is radiolucent, but according to White and Farrow, it is given as radio opaque. Okay, because that basing upon the different types of GIC composition. But whenever they ask a question, okay, I want you to go with radiolucent as an answer. The reason is, we'll see, like probably a dental material related question may be inclined to dental materials. So thinking that it's a radiolucent, but it's a question of controversy. It varies. Phillips is telling radiolucent. White and Farrow is telling radio opaque. That is basically basing upon the ingredients. It is basically. Okay. So apart from this, I just want to add a particular note. Fluoride release is maximum with which cement? Because you have a question of fluoride release, fluoride recharge. Two overlapped questions were given. Okay, so right. So if the question is very simple, straight away, maybe silicates are not in use. The question was given in such a way, a baby of high caries index uh, with lots of caries lesions has approached to the OPD, and which of the following restorative material which has high fluoride releasing capacity has to be used in this baby? If the option is having silicates, maybe if we are not, even now you're not using silicates, your answer should be silicates only, because silicates is having the highest fluoride release. That is, as someone is telling, that it is 20 ppm. What is the GAC ppm? Yes, GAC ppm is around like 5 ppm. Silicates is 20 solid. Any other points you want to add to silicate cements? Silicates are contraindicated in which patients? Silicates are contraindicated in which patients? Silicates are contraindicated in mouth breathers. Lifespan of silicate registration is 4 years. Silicates are most commonly used in high caries risk patients. If silicates is not there in the options, then the game is, then the game is different. I want you to add this particular sequence. If silicates is not there in the options, then your sequence is this. Conventional GIC is going to have more fluoride release, followed by resin modified GIC, followed by compomer, and the least is composite. I'm not talking about the smart composites. I'm talking about a regular composite. Okay. The fluoride release is maximum with silicates, followed by conventional GIC, followed by resin modified GIC, followed by compomer, followed by composite. Clear? They are asking such a questions last one bouncer, but basically I don't consider this as a bouncer because I have discussed this for the last year students. I don't consider this as a bouncer. But my only bouncer question in the last year exams was the mini field wala question is a bouncer. Okay, most of them they went wrong in the mini field question because that is completely out of globe. Okay, right. So next one is coming to matrix bands. Have you seen this matrix band? Ivory number 8. This is there in my kit in first BDS, but I have never used it. Rarely, once my senior forced me to use it. Okay. Okay, right. So easy to identify. 1 looks like 8, 8 looks like 1. Okay. So, okay. So you check out this ivory 8, it looks like 1. And ivory 1, it looks like 8. Okay. Clear? 1 looks like 8 and 8 looks like 1. The next one, have you seen this anywhere? Self-adjusting or sequel and okay. Normally, whenever you see teeth, the teeth will have a different dimensions at occlusal part and different dimensions at the cervical part. So this is a matrix band which has 2 ends. Okay. One is the larger diameter, which is the occlusal end, smaller diameter, which is gingival end. It has 2 matrix bands. One is the larger matrix band. Second one is a smaller matrix band that adapts to the tooth counter and it is used regularly without a wedge. Self-adjusting. So it adjusts by itself. So there is no need of a wedge. So that is called a sequel and self-adjusting matrix band that is regularly useful for a tapered teeth, which has 2 different bands, one band for the occlusal end, second band for the gingival end. The next comes again a frequent diagram-based question was given on this. So this is called as auto matrix. You can see it looking like a roll. So this is called as roll in band matrix. So it's a roll in matrix band system. The band and retainer are available basically as a single unit. You can see this is available as a single unit. This is most commonly used in the patients who cannot tolerate retainers, heavy retainers, or particularly used in the cases where there is partially erupted teeth. So they can ask you a diagram-based question over this. So these are the diagram-based questions of this auto matrix system. Again, you have a question on this INICET. The question was given. So that is the reason why I have kept it. So this is called as cervical matrix. This is called as cervical matrix, which is basically used to hold class 5 registration, cervical matrix. Okay, you have a handle and you have a transparent glass, like a plastic like frame through which you can cure the composite. So this is called as transparent cervical matrices. Clear, guys? Clear? No, the main motto of bootcamp series, particularly this year, we have not done it in the last couple of years, is extensive revision. Okay. So it's going to be like it is something like a added petrol to your fire. You're already on fire. So this is going to add a petrol. So that's going to make your preparation so aggressive. And from my point of view, even if you know whatever I'm discussing, like whatever I'm talking here and there, you may know, but my consent is uh, this is going to be more effective and productive, and this is going to give you high and confidence only if you attend this live. Only I can openly tell. Okay, you can watch it as a recorded version, you can watch it n times, but once you're done with the session of 1.5 to 2 hours, particularly my session, okay, it's going to give you sound knowledge, and it's going to make you feel that you learned so much in the last couple of minutes. That's 90 or 120 minutes, let it be the class. You're going to get exposed to lots of questions from uh, uh, multiple subjects. Okay, right? So please try your best to attend it as live. I'm not blaming the people who are watching it as a recorded version, but this impact will be more in the live session itself. Okay, clear? Okay, can I move ahead? Okay, right. So now coming to the width of the different types of registrations, comparison to the intercuspal distance. If in the case of amalgam, in the adult, it is 1/4 to 1/5, preferably 1/4 is the best option if both are there. And in the pedo, it is 1/3, and in the inlay, it is 1/3, and the onlay, it is greater than 1/3. Can anyone tell me what is direct filling gold? Anyone? What is this value for direct filling gold? Yes, very good. It is 1/5. Then comes finishing and polishing is important. Even last year, 2024 NEET, you have a question on finishing and polishing. So these are the polishing agents that are regularly used for different materials. And please do make a note of it. Very, very important from examination point of view. I'll just try to focus on the questions which are previously given. Okay, one is chalk for amalgam. Tin oxide for amalgam was given previously. Okay, one. Second one, noble metals. Okay, particularly they have given gold. Okay, gold. Noble metals. Okay, noble metals is rogue, that is iron oxide. This question was given. Stainless steel was given, that is called as whitening agent, that is called as chromium oxide. And of course, you know that artificial teeth or dentures and all these are cleaned by pumice. Most of you are familiar. Okay, then the next comes a little bit about amalgam. So ADA specification number of amalgam, already discussed, that most of you are familiar. What is the ADA specification number of mercury? Yes, right, 6. GIC? 66. Very nice. So ADA specification number of amalgam 1, that is clearly telling that amalgam should contain 65% of silver, 29% of tin, and 5 to 6% of copper. So copper containing alloys are going to have how much? Copper containing. Copper containing are more than 6, and copper free, high copper are more than 6, and low copper are less than 6. Okay, right. What is this cut chunk method? Cut chunk method is basically a technique of choice that is helpful in removal of amalgam. And of course, we have discussed amalgam is going to cause type 4 hypersensitivity, mercury allergy type 4 hypersensitivity. What type of vision you see in mercury poisoning cases? Right. So tunnel vision is seen in the case of tunnel vision. Tunnel vision is seen in the case of mercury poisoning cases. Very good. So refractive index of a teeth is, yesterday we have discussed in the WhatsApp activity, refractive index of a teeth. Yes, refractive index of a teeth is 1.67. Coefficient of thermal expansion of a teeth, preferably I'm asking enamel. Coefficient of thermal expansion of amalgam is Not 1. Yes, very good, Shiva. 11.4 into 10 to the power of -6. So if you just compare the coefficient of thermal expansion of enamel to that of the amalgam is somewhere around like more than 2 to 2.4 times. It is 2.4 times, 2 to 2.4 times more. So what is the recommended condensation force of amalgam? It is same for direct filling gold also. So recommendation condensation force of amalgam is 15 lbs. It is same for the direct filling gold, but we regularly don't use such a recommendation force for amalgam. Okay, but what the force we use? Force we use is used forces. Direct filling gold amalgam 15 lbs. That is a recommended. Whenever you see the word recommended, then your answer should be 15 lbs. So what we regularly use is 1 to 2 kgs or 3 to 4 lbs. Regularly used is 1 to 2 kgs or 3 to 4 lbs. Regularly recommended is 15 lbs. So what is this universal cervical retainer number? Universal cervical retainer number. Cervical retainer they regularly asked 212. This is a diagram based question that they can ask you. 212. A little bit about rubber dam sheets. Again, we are going to do the extensive part in the pedo. So normal rubber dam sheet dimensions are. So normal rubber dam sheet dimensions are. Yes, it is 6 into 6. For children, it is 5 into 5. For an adult, it is 6 into 6. For children, it is 5 into 5. The shiny side is placed towards the tissue, whereas the dull side is placed towards the occlusal surface. Because if the shiny side is placed towards the occlusal surface, it's going to reflect the light and it's going to obstruct your vision. Thickness is very, very important. Thickness, both inches and millimeters, is very, very important. So what thickness is regularly used in endo and pedo? What thickness is regularly used in endo and pedo? Not heavy. Yes, right, medium. Regularly heavy, extra heavy, special heavy are useful for regularly heavy, extra heavy, special. Whenever you require extra retraction, that is in the case of your class 5s. So whenever you have class 5 registrations, you require extra retraction. Okay, in such cases, you have to go for a thicker dams. So yesterday we have already done. So what is this? Because these questions were given in the exam. So this is a rubber dam punch. You can see holes are there. So basing upon the size of the teeth which you are going, you have to keep a hole. And what is the skeletal reference for this? What reference is going to tell you you have to keep hole at this particular location? Yes, that is called as template. That is called as rubber dam template is going to tell you, yes, for this particular teeth, you have to keep hole at this particular place. So this is called as rubber dam. The next diagram is rubber dam. Yes, that is called as rubber dam forceps. And I hope you know the rubber dam retainer and everything. So distance between the two holes in the rubber dam is 6.3 millimeters. Also called as 6.3 millimeters or how many inches? Yes, very good. That is very important. 1/4 inch, because 1/4 inch is something where you get in many, many places. So what is the sprue angle? The sprue angle is 45 degrees or 135 degrees. What is liner thickness? The liner thickness should be at least 1 millimeter. And the liner should be short. The casting ring liner should be short to the open end. Short to the open end by 3.25 millimeters. If it is gypsum bonded investment, the thickness should be 6 millimeters. If it is phosphide bonded investment, the thickness should be 3 to 4 millimeters. If multiple wax patterns are used, the distance between them should be. If multiple wax patterns are used, the distance between them should be minimum 3 millimeters. I'm just trying to incline to prosto also. The gap that is present between your fontic and your ridge in the case of hygienic fontic is. Yes, the thickness of hygienic fontic is 3 millimeters and the gap between the ridge should be 3 millimeters. Any rule of 3 I made you to make a note? Endo. This is my rule of 3, not textbook rule of 3. Easy to remember. The size of hole that you are going to create in the case of your microsurgery. Microsurgery, you need to create a hole to get access to the root. What is the size of the hole? In advanced microsurgery, I'm talking about modern endodontics. Yes, it is 3 to 4 millimeters. Very good. Amount of root and resection done. Amount of root and resection done. Yes, it is 3 millimeters. Reason for 3 millimeters root and resection is at 3 millimeters, you are going to remove 98% of apical ramifications and 93% of lateral ramifications. And root and filling, how much millimeters? Yes, root and filling is also 3 millimeters. This is my rule of 3. Easy to remember. Hole you keep is 3 millimeters to 4 millimeters. Cut 3 millimeters, fill 3 millimeters. All are 3. Rule of 3. Okay, guys, I'm done for now. Because this is an integrated to pedo part also. So I'll try to continue the leftover things what I thought of discussing with you in the next session. That is operative integrated pedo. Okay, so I'll update you probably. I'll take pedo. Okay, I'll take pedo probably within not tomorrow, day after tomorrow. I'm going to take it again. Okay, I'll update you regarding that on the regular WhatsApp group where we are in touch. Okay, done. Okay, so done for today. Take care, study well. Okay, so try to focus and try to cover as much as you can before the dates are going to come out. The only great suggestion I can give you, because I'm monitoring the aspirants from last 10 years, being an aspirant for 2 to 3 years. So I'm seeing the mindset of these individuals from last couple of years. So what I can tell you is the only huge thing that I have, the huge difference that I have seen is exams dates are unpredictable. Exam pattern is also unpredictable. Right? Everything around us is unpredictable. Counselings are unpredictable. Okay, you see, I still remember in 2012, the first NEET exam, first exam I have given is a NEET exam, and exam was done, result was out, and it was cancelled. Means I have seen an era where exam was given, result was out, very happy, exam was cancelled. On other hand, I am only one batch in entire dentistry where the dentistry for us is 5.5 years. Ours is the only batch. Dentistry is normally 5 years, but I am the only batch, 2012 batch. So my dentistry is 5.5 years where I have 5 years of study and 6 months of internship. Mine is the only batch in the country, only batch of dentists in the country where we have only 6 months of internship. So I have seen all the sides of dentistry. Okay, so dentistry is really unpredictable. Exams are unpredictable. Profession is unpredictable. Everything is unpredictable. But after being an intern, like in 2012, 2013, 10 years, 11 years from now, with this experience, what I can tell is it is very, very easy to be successful in dentistry. So when everything is unpredictable around you, what should be you? How should be you? You know, something very unpredictable. People are not serious in it. People are not focused in it. People are scared about this because it's unpredictable. The only mantra to be successful in dentistry is you become predictable. If you are predictable, if you are working hard, keeping your targets, keeping your goals from the day one till the last date. If you're doing this constantly, repeatedly, again and again, with good positive mindset, it is very easy for us to be successful in dentistry. This will not work out for the medical profession. This will not work out for MBBS people. Okay. This is going to work out for us because our profession, our scenarios, our exams, our things are completely rarely unpredictable. And this is not something new for you. This is not something new for me because I am being exposed to this type of uneven sort of things from 2012 once I'm done with my internship. You just see the scenario where you have given exam, result was out, you're celebrating and exam was cancelled. That is going to be the most worst, right? So it's unpredictable. What made me or my few of my friends to reach some very good destinies in their profession is these guys are predictable here. People who are predictable, I have seen in my journey of 10 to 12 years, my batchmates, let it be my juniors, my students, all the people who are successful now today are predictable guys. They are predictable. Whatever the scenario is, these people are predictable. The only thing here is easy is very easy. Let it be, I'm not talking about exam, I'm talking about every step in dentistry, every level in dentistry. Let it be a PG. You want to be successful, you try to be predictable because everything around is not predictable. COVID may come, rainfall is there, patients will not come. HOD may be strict, HOD may change, guides may change. A bad HOD can become a good HOD can become a bad HOD, college OP may drop, rules, regulations in the college may change, university rules may change, everything will change around you. The only thing that you should not change is you. If you want to be in this game, if you want to survive in India as a dentist, the only mantra I can suggest you is let it be everything around you is non-predictable. I want you to be predictable. If you are predictable, the game is very simple. Okay, done. Take care. Bye. See you.